Trying to get some technical issues together, but I think everyone can hear me. But my name is Chris Lefevre. I'm a physical therapist out of the Olympic and Paralympic Training Center in Colorado Springs. And today we'll be talking about the post-operative rehabilitative hip. And this will be specifically on the arthroscopic hip. We're going to talk primarily about labral repairs and osteochondroplasties of FAI. Apologies if I stop every once in a while. I have some people entering the room here. All right, in terms of lecture goals, we're going to highlight different surgical considerations that make an impact on decisions made by the rehabilitative clinician. So I think in the PT world, the conservative care world, whether you're an AT or a DC or a PT, we like to know what happens in surgery, but what actually happens in surgery that makes like a tangible, real impact over the course of the rehabilitative post-op journey. We're going to review the full course of rehab following an arthroscopic hip surgery. Hip care is a little bit more niche. I think most of us are most familiar with shoulders and knees. So it's good to have kind of an idea of the timelines and some of the different pearls and pitfalls of what you should have in mind after hip surgery. We're going to identify the major milestones, the do's and don'ts, and then some other hip-specific rehabilitative pearls. And then finally, we're going to end with reviewing hip-specific return-to-play testing and then return-to-play rates following hip arthroscopy. I have no real relevant disclosures, but I do have some housekeeping. So two of my overarching thoughts on long-term rehabs: there are really so few absolute wrong answers in PT, and that may sound strange, but what I mean is the rehabilitative journey is Jenny, can you give me a thumbs up if I still have audio? Okay, cool. And what I mean by this is the rehabilitative journey after surgery is usually a 6, 9 month, 10-month long process. And how the patient looks at the end is the result of a bunch of cumulative decisions coming together. So there are very few like wrong, tangible, acute answers that you can have over the course of rehab. But what I will say is we like the rehab journey to be smooth, like our path on the left, versus something like our path on the right. You can take a very average clinician and you can take a very excellent clinician. And at that 9-month return to play mark, the patient will likely look the same, but did their journey to them feel the same? So being proficient with some of this post-operative knowledge is what makes you look more like the left-hand pitcher versus the right. And I think that's a really important takeaway from all this. So before we talk about post-operative rehab of the hip, we're going to talk about kind of what your ideal candidate for arthroscopic hip surgery is. So what does this patient look like? So the first thing that we'll talk about kind of in the hip world, a big thing that you'll hear people talk about is the C sign distribution. It's people, they form a C with their hand and they put that over the basically the anterior thigh crease and they say, I have pain here. It's very common that hip pain presents in this area. It's usually indicative of something intra-articular, but you can certainly also have back pain, glute pain, lateral hip pain, and anterior hip pain, which makes this sometimes very challenging to give these patients a definitive diagnosis. Most of these folks will have persistent mechanical symptoms, clicking, locking, and sometimes giving way if severe enough. And their mechanism of injury is often from a cutting type sport with repetitive twisting, cutting, and pivoting. But interestingly enough, there's this large subset of patients that just kind of have symptoms that develop insidiously and without real reason. It starts off as mild and then it progressively gets worse to the point that it affects their ability to do everyday life and it affects their ability to do their sport. In terms of special positive special testing, you have your Fader, your log roll, and your Thomas tests. And these are all better used as screening tools. They're not as good as diagnostic tools. They'll let you know that there might be something intra-articular, but the actual clinometric properties of these tests are fairly poor. So it's just important to know how to use these. They don't tell you what's going on within the hip exactly, but they let you know that there might be something in the hip that is the issue at hand. In terms of the duration of symptoms prior to the start of surgery, there's no real set recommendation. This largely varies by the surgeon and is probably then influenced by patient urgency. We know some patients want surgery right away, while others want to try and delay it. But generally, your typical outpatient orthopedist or primary care physician will say, go try physical therapy anywhere from 4 to 6 weeks. Typically, if you're going to surgery, you've experienced a failed bout of PT, which physical therapists like to make fun of this phrase. We don't exactly know what it means. Does it mean the PT wasn't intense enough? Does it mean the patient wasn't adherent enough to the physical therapy plan of care? There's a lot of different things that can be wrapped up into this term, but certainly before you have surgery, you've tried physical therapy and some other conservative means. You're going to want to have some positive imaging that comes with it. An MR with contrast is going to have a much higher sensitivity and accuracy compared to just its MRI counterpart. An MRA has a 90% sensitivity and a 91% accuracy, whereas its MRI counterpart is in the 30%. Okay, and then often these patients have tried corticosteroid injections and PRP injections, and typically if they're pursuing surgery, they've had little response from these interventions. But what it really boils down to is that the demands of sport are persistently exceeding the tolerance of the hip, and then the demands of life persistently exceed the tolerance of the hip. And that's what usually drives these patients to see a hip arthroscopist for consult. So I have two different patient cases here. I asked these patients to, let's see, I'm just going to enable this. Sorry about that. I have two videos here of two recent patients I've worked with. They were kind enough to share their stories. I'm going to let this play, and this should have audio. I tested it yesterday with someone else, but they're going to give you kind of their initial symptoms, their mechanism of injury, how long they tried conservative care before they pursued surgery, and just some different insights as to what their experience was. And both these patients had hip labral repairs and then osteochondroplasties to correct pincer and cam lesions. So let's see if this plays here.
Okay, my hip injury started back in 2019. I did physical therapy with the Team USA Dr. Kathy Arnott for Team USA shooting. She did the therapy with me for 2 years. Basically, the initial pains or like the signs that we found that I had labrum tear was a pain right here in my ingroin. It was a very painful part, especially when I was running. We didn't know if it started with the running. I am a pistol shooter again, but I like to run a lot. And we thought that it was the running, but then talking with the surgeon, it seems that it could be the shooting as well. I am the third person in nation that has this type of surgery. The other two are rifle shooters, and they had it on the right side because they loaded on that side. And I am a pistol shooter, and I had it on the left side. So they cannot really say that is the reason why I turned my labrum. And then I decided to have surgery because after 2 years of doing physical therapy and trying to do lots of treatments to kind of avoid the surgery, I got to a point that I couldn't run anymore. I couldn't shoot anymore like the way that I was shooting it before. And I couldn't lift. And my life was just not the same. I'm a very active person, and then we decided to go for surgery.
So keep some of that in mind there. She used, again, that classic C sign kind of symptom to describe the onset of her pain, had no real mechanism of injury, and tried for 2 years before she pursued surgery. So compare and contrast that to our next patient. This is Brendan. He's one of our modern pentathletes, and I'll let him share his story here quick.
Hi, my name is Brendan Anderson. I'm a modern pentathlete for Team USA. I received hip surgery from the Sedman Clinic in December of 2021 for my left hip. It was a labor repair and FAI surgery, followed by physical therapy with Crystal Fever and Olivia Rowland at the Olympic Training Center in Colorado Springs. I initially noticed pain in my left hip beginning in November of 2019. So it was about 2 years of chronic pain in the anterior part of my left hip. That also included lower back pain on primarily my left side, but also my right side as well. I would have multiple back spasms as well as inflammation in my facet joints. I noticed the pain was immediate during an intense running workout, and the pain seemed to increase from running and fencing training throughout the 2 years. It was chronic at that point, which was the real breaking point.
So again, another case where where Brendan waited 2 years before pursuing surgery, and his hip presented with back pain as well. It's kind of interesting. There's a very famous kind of fact that's always given out in these hip presentations that on average, a patient with hip pain takes at least 4 different medical providers before they get a definitive diagnosis for their hip. And it's just very common for these patients to kind of float around in the medical system before they get really clear definitive care that's purposeful. So just wanted to show this quick. This is again that C sign. This is out of a piece of literature by Dr. Bird, a very famous hip arthroscopist. And this is what a lot of these patients will classically present with. If you're not familiar with the Fader test, this stands for flexion, adduction, and internal rotation. And the thought is, as you come into this position, if you have a cam lesion, which is a deformity of the femoral neck, you'll get abutment of the femoral neck or the femoral head up against the acetabular rim, and you can be quite uncomfortable. The log roll is a fairly specific test. The patient lays in supine. You roll the leg into internal rotation, feeling for basically an end feel and comparing that to their uninvolved side. Is it boggy? Is it pinchy? Do they get pain in the end range? And is their range limited from side to side? And this can often give you good information. And then finally, the Thomas test. This is Mike Ryman here, a fantastic physical therapist out of Duke University, very well researched in the hip world. And the Thomas test can be used to look for intra-articular hip pathology in addition to its original intention, which is to measure hip flexor flexibility. But if you have a cranky anterior hip capsule and you bring the hip into extension, it's quite painful for these patients, and very often, like the fall through phase of a gait before pre-swing, and their hip is in extension behind them, it tends to be very uncomfortable for them. So those are some of your big special tests. So in terms of different surgical considerations, we're going to talk about what happens in surgery and some of the things that the rehabilitative clinician should keep in mind over the next 6 plus or minus 2 months over the course of that patient's rehab. So hip arthroscopy is typically an outpatient procedure. The patient is typically positioned in a supine on a modified fracture table, or with a perennial post that's lateralized to the opposite or to the operative side. Depending on the training of the surgeon or their preference, you can also do this in lateral decubitus position, and we're going to show you pictures of that. And then typically the non-operative hip is abducted to allow placement of a draped C-arm. So you can take live images with fluoroscopy. So the hip arthroscopist can make sure that they're not taking down too much bone when they're doing the osteoplasty. So here's an illustration of what this looks like. You have this peroneal post, which basically it holds the pelvis and the patient's body in place. And the distal extremity is fixed into a specialized piece of equipment that, as you apply traction, you can get traction at the hip for the hip arthroscopist to work in. It's important to note that for the arthroscopist, working within a shoulder or a knee has far more much space than in the hip, and the hip is quite challenging to often navigate in. So having good distraction is very important. For an actual picture of this, you have obviously a supine position at the top, and then a lateral decubitus position at the bottom here. Okay. I will also say that a lot of different operative centers are switching to different equipment to kind of resist some of the different, we'll call them post-operative complications or neuropraxias that sometimes are associated with these posts. So anytime you see a slide in red, these are key takeaways that you should remember if you're the rehabilitative clinician working with one of these patients. So again, we were talking just now about the configuration of that post, and the distraction of the leg against that post sometimes places the patient at risk for pudendal nerve neuropraxias. And these aren't uncommon, with rates reported anywhere from 2% to 28%. And these can be quite painful. You can see in the illustration on the right-hand side, almost like a saddle anesthesia distribution. You can see in the blue where that affects people. And it's really a painful sensory experience and presents with a lot of sexual disorders for these patients. It's important to note these do tend to spontaneously resolve, and usually closer to 6 or to 3 weeks, but it can last up to 6 months. But it's important to let these patients know that this will get better, because it can be quite debilitating. So traction is applied to that operative extremity, typically requires 25 to 50 pounds. And sometimes after you apply that, you have to let it wait for the capsule to actually accommodate those forces, and you get some separation of the joint. And a lot of different, if you follow any of the hip arthroscopists on Instagram or physical therapists on Instagram that have big hip practices, they always talk about this vacuum phenomenon that's shared between the femoral head and the labrum of the acetabulum. And when that's released, it literally looks like a suction cup, and the femoral head is pulled away from the joint. So the seal is basically further released once the joint is distended with fluid for surgery, and then fluoroscopy will confirm the distraction of that joint. So some of my sources here are from Instagram, but I promise they're just videos. But this is a hip that has been the labrum has been repaired, and you can see that they did osteochondroplasty here. But basically, as they apply distraction, you can kind of see that vacuum phenomenon taking place. I'm gonna play one more time there. Okay. So next we'll talk about the different portals that are used. So typically there's an anterior, lateral, and posterior lateral. And again, for the post-operative rehabilitation, this isn't necessarily important, but the anatomy that these different portal sites gives some controlled trauma to is important for the physical therapist or athletic trainer to know. So here are your different portal sites if you just want to try and visualize what they would look like on your patient. In the anterior portal here, we have it highlighted in red by arrow. It's typically placed 6 centimeters distal to the ASIS. And this penetrates through the sartorius, the rectus femoris, and then finally the joint capsule. The big neurovascular structure of concern here is the lateral femoral cutaneous nerve. It's a sensory nerve that is sometimes affected after hip surgery. Your femoral nerve and the ascending branch of the lateral circumflex artery. So what can happen in these patients is sometimes iatrogenic lateral femoral cutaneous nerve injury. It's also called a myalgia paresthetica. And it's quite common, and this can appear on kind of the lateral hip. It's purely a sensory nerve. So, it's basically classified this as a neuropraxia. And these patients can get really painful numbness, tingling, and burning. And it's typically caused by the initial incision for the anterior portal. So on the left-hand side here, you can see in the dark blue, that's the sensory distribution of this nerve. And on the right-hand side here is a very useful cadaveric picture. Just kind of fun hip fact in the general outpatient population that are not post-operative. Folks that experience these are usually women with very tight jeans, or guys with very tight jeans, or truck drivers with big bellies. They're on the road for hours at end are very high suspect to develop this as well. Again, purely a sensory nerve kind of thing, and very uncomfortable. So next, if you go to anterior lateral portal, you have the superior gluteal nerve that's close to that. And then the posterior lateral portal penetrates glute med, glute min, and then the lateral capsule at its posterior margin. And then the sciatic nerve is close to this as well. So just consider the implications that this is going to have on basically doing isometric glute sets, which is one of the kind of key exercises you do after these hip surgeries. But also appreciate here on the right-hand side where the red arrow is drawn is typically where this portal and then the instruments will run through. And then the small S there, that's the sciatic nerve. So you can appreciate that you may have some sciatic nerve neuropraxia or adverse neural tension after these surgeries, depending how long they spend in traction. So just something to keep in mind. And like we already talked about, the glute med and the glute min are going to experience having arthroscopic tools run through them, and just consider the impact of this on the post-operative glute set and then hip abduction strength as well. And then finally, one last illustration, you can just appreciate the neurovascular structures around these portal sites that we just talked about. So let's see, sorry, I have some more people I have to admit here. Okay, so basic steps for hip arthroscopy. You have your portals that are established. Basically, a capsulotomy is performed, and we'll talk about this here in a bit. It's basically when they make an incision in the capsule and spread it open, so they have basically more room to work within and better visualize the joint. An electric burr is used to perform the osteochondroplasty of the acetabular rim and take down the pincer lesion. A suture is passed through the torn labrum, and many anchors are used to reattach that back to achieve its the suction seal that was likely lost from the damage that they're doing the surgery for. The burr is then used to shave off excess bone from around the femoral neck or the cam lesion. And then finally, the orthopedic surgeon will resolve the capsulotomy by closing the capsule. So again, for our purposes today, basically any penetration of the capsule, we're going to be calling a capsulotomy. And there are different variants that exist, including a limited capsulotomy and interportal capsulotomy, but probably the most famous or common one is a T capsulotomy. And the goal is to achieve better visualization. Appreciate that this affects the iliofemoral ligament, and momentarily in surgery, it's going to inherently disrupt the hip capsule and the stability of it. So these are 3 different pictures from a cadaveric study. On the left-hand side, again, you're looking at the anterior hip here, and you can see a small incision is placed there. That's called an interportal capsulotomy. In the middle, they extend another line down, basically between in the middle of that incision to create a T capsulotomy. And then on the right-hand side, you see a repaired T capsulotomy of what that will look like when the surgeon resolves the capsulotomy at the end of the surgery. Here's another nice illustration just to drive that point home. In the past, capsulotomies were previously left open, and this was leading to iatrogenic hip instabilities. And now the standard is certainly to close these. Okay, probably one of the single largest contraindications for the physical therapist or athletic trainer or chiropractor when rehabbing these patients is basically slamming the patient into aggressive external rotation. It would probably take someone pretty negligent to do this, but appreciate that external rotation, an extension of the hip, can basically rupture the repaired capsulotomy, which would not be a good thing. So typically in post-operative rehab, you have precautions that last anywhere from 2 to 4 weeks in length, depending on surgeon preference. And again, this would be pretty hard to do, but crazier things have happened. So next we'll talk about actual physical therapy or rehab of the post-operative arthroscopic hip, and we'll talk about some milestones, pearls, and pitfalls. Some more housekeeping kind of thing. I'm not a huge fan of protocols. I'm more of a fan of principles, which is what we're going to focus on mainly today. Again, principles are probably sound and universal, but some of the different things that we'll talk about may be different from what you've seen in protocols. It doesn't make it right or wrong. Again, as long as there are sound principles behind it and you're having a close relationship with the hip arthroscopist that did the surgery. So at the bottom of your screen, you're going to have a black line, and this black line will kind of keep us in place of where we're at across the post-operative journey for these patients. So feel free to reference that often if you feel like you're getting lost timeline-wise. When I worked at Duke, I worked with a hip arthroscopist named Dr. Mather, and he would always tell his patients this, and he would always teach his physical therapist this as well. But basically 4 stages of the post-operative hip, and I think these are fantastic. This is how I frame my thought process. First, we want to try and establish a quiet hip. Then we want to establish a coordinated hip. Okay, sorry, more people come in the room here. A strengthened hip, and then finally a dynamic hip. And this will kind of make more sense as we walk through and we narrate each one of these phases. So in the initial first 0 to 6 weeks, our basic goals are to protect the joint, preserve the integrity of the surgery, obviously, restore ambulation, and help our patient get back to activities of daily living. It's characterized by range of motion limitations, weight-bearing limitations, brace and crutch use. And then I'm not a really big fan of the term muscle activation, but in essence, it's not completely wrong. A lot of the different therapeutic exercises that you're going to be doing immediately after surgery are just that. You're going to be practicing isometric contractions of the gluteal muscle and the quadriceps. So those are big themes for this. This will differ anywhere between week 0 to week 4. Sometimes it can extend out to week 6, depending how conservative the surgical team is. But typically flexion is limited to 90 degrees. Obviously, you don't want to abut up into the area that's just been worked on. It's likely a very cranky acetabular rim with a recently repaired labrum, so we're not going to stress that. Abduction typically allowed 0 to 45 degrees. External rotation we're going to do in supine position and basically with a log roll position. Again, referencing earlier, we're not going to push that too hard. And then extension, we're generally going to keep to 0. And again, in small text here, this is going to move slower if a capsular plication or stability-based procedure was performed an adjunct to all the different work we're talking about now. But again, this presentation is related to just straightforward labral repair with osteochondroplasty. And then typically at weeks 3+ or weeks 4+, these are just progressed in a pain-free progression as appropriate. So basic post-operative hip range of motion, not a very exciting video, but it's important to kind of talk about. So this is going to be your hip external rotation. You can just do this into some general external rotation as the patient lays there and relaxes. Next is internal rotation. You can do this as much as you'd like. While they're in supine, this won't cause any symptoms of impingement. Certainly if they were in higher degrees of flexion, it likely would. Next is hip abduction. I'm probably talking about the weather or something that happened in the news here. Real easy. The patient's job is to just keep the hip completely quiet during this. And then finally, some careful hand position changes here. And then we're just working on hip flexion. Again, working up to 90, not past it. And you'll probably find in the first couple of weeks, they'll start to have some symptoms around 70 degrees. So just remaining conscious of that. Okay, I didn't take a video for this because I didn't think anyone wanted to see a video of just Jenny laying on her stomach, but this is prone lying. It's basically just going to help to maintain hip extension. If that feels comfortable for the patient, they can experiment with a little bit of prone on elbows. Often we'll steal the term tummy time from our friends in pediatrics while describing this to patients. And if they can practice this at home, laying on the ground, watching TV, that's always a good idea. So another key takeaway here, kind of unique to hip surgery, you see some of this carry over into post-operative rehab for the shoulder, but is basically this circumduction therapy. So the goal is we want to prevent intra-articular development of adhesions following hip arthroscopy. And there's a very commonly cited study from 2013 that looked at 1,300 patients following hip arthroscopy. And patients who did not receive circumduction therapy were basically 4 times more likely to develop adhesions. Interestingly enough, and this is the population that we see here at the training center, is patients under 30 years old are 6 times more likely to develop adhesions. I just thought this was interesting as well. I have to think about this a little bit more to come up with a good reason for it, but patients who undergo microfracture are less likely to develop adhesions. So just kind of know your patient and have these things in mind as you're doing your initial evaluation and getting their history and what happened within the operating room. In terms of how much to do, my personal recommendation is 4 times daily, 10 to 15-minute bouts. You can teach a family member how to safely do this. Certainly, they'll get a bout or 2 while they're at physical therapy with you, or if they're seeing an athletic trainer or a chiropractor. And there are certainly other philosophies. Sometimes you have surgeons that tell patients just a ridiculous amount that they're never going to achieve, but they'll probably fall somewhere that's going to keep the hip mobile. It works, but at the cost of the physical therapist constantly reassuring them that they're going to be okay and accepting their apologies. So my personal belief is give them something that they can be realistic with, but stress the importance of actually doing their homework, because this is a big deal. Okay, in terms of what circumduction looks like, so I usually have the patient in supine. They're going to scoot closer to the side of the table where I am. You can see me there. Their job is to keep their hip flexor completely quiet, which we're going to talk about here in a bit. Okay, just testing the tolerance of kind of what she can feel there as we go into hip flexion. The closer you can keep basically the lateral aspect of the femur and the tibia to the body of the clinician, the more comfortable the patient is going to be in letting you take the hip. And then you just do little circles, clockwise, counterclockwise. Again, by this point, I'm probably run out of things to talk about. Maybe we moved on to sports or something like that, but 10 to 15 minutes of this 4 times a day are my personal recommendations. Once you get past that 3rd week or that 4th week, my personal belief is that these passive range of motion exercises now become active and they now belong to the patient. So it's their responsibility to continue these so we can focus our efforts elsewhere while they're in physical therapy. I'll show you kind of how they can do this safely on their own. Let's see if this video plays here. These are just called quadruped rockbacks. You can get a little bit of weight through the hip joint there, test their tolerance. If it's too much weight, they can easily shift to the other side, but just rocking back. This is a continuation from the tummy time that we talked about earlier. Basically, prone press-ups is going to be their first real introduction of hip extension. And then supine windshield wipers. Naturally, you're going to kind of warn your patient they don't have to push really far into internal rotation on that side. Again, keep in mind the hip's not at 90 degrees, so the likelihood of impinging there is probably low, but just keeping that in mind that it can be uncomfortable for some. In terms of weight-bearing, crutches, and brace, the protocols are all over the place with this. It usually depends on surgeon preference. Typically, this will last longer if different chondral pathologies or surgical procedures are kind of added on top of, just your osteochondroplasty and your labral repair. But the brace, it lets people know you've had surgery. It reminds you that you've had surgery. You can limit the patient's ability to go into extension with their hip, which we know is quite painful after surgery. And it probably limits a little bit of internal and external rotation and honors some of those capsulotomy restrictions afterwards. Typically anywhere from 0 to 4 weeks, we want to have partial weight bearing. And then anywhere between 4 and 6 weeks, again, depending on the surgeon, depending on the protocol, we can discharge this once gait is restored. So we called it partial weight bearing before, and we want to talk about why that language is important and why we don't use the term toe touch weight bearing. So basically, toe touch weight bearing encourages slight hip flexion, and then you have your patients that they're holding unconsciously, basically submaximal hip flexion isometrics all throughout the day whenever they're standing or they're walking. The hip flexor is very prone to getting irritable after a hip arthroscopy, and we want to make sure that we load this thoughtfully and avoid basically development of a really hot irritable hip flexor tendinopathy. The incidence of this tendinopathy is about 7% in this crowd. And instead, we want to use terminology like foot flat partial weight bearing, which encourages better posturing throughout the day. And a reactive hip flexor tendinopathy, if you haven't treated one, they're very challenging to manage. It's almost synonymous with the patellar tendinopathy that develops after ACL reconstruction. And between the two, I would take the patellar tendinopathy any day because a very hot, irritable hip is very challenging to calm down. Okay, so just kind of drive this point home. On the left-hand side here, you see me doing toe touch weight bearing. And on the right-hand side, you see foot flat partial weight bearing. Okay, here are some of the basic therapeutic exercises that you can do. There are so many right answers to this. I'm sure there are many exercises that I missed, but these are some of the common ones that I'll focus on. Obviously, you have all your isometrics from 0 to 3 weeks out. And then from 3 to 6 weeks, the big thing here is that you're going to introduce the stationary bike. And you're just going to make sure that there's no strap over the dorsum of the foot. When you put that strap there, it encourages the patient to pull up into hip flexion and can sometimes activate the hip flexor more than you'd like to. That's going to be a very controlled variable set by the rehabilitative clinician, and adding in a whole bunch of that over the course of 5 or 10 minutes of biking can sometimes be too much. But again, tons of right answers here. I'm sure many of the folks in this audience could add more that I've missed. So it's funny, here I am talking about how there's so few wrong answers. Probably a wrong answer after hip arthroscopy is doing straight leg raises. It's a really long lever arm. It's likely too aggressive, and you'll probably flare up the anterior hip by doing too many of these. You're going to need to be a bit more thoughtful when starting to load the hip flexor. And when it comes down to it, there's better ways to strengthen the quad than straight leg raises. And reconsider clamshells. Clamshells are kind of this generic vanilla exercise we give to everyone, especially our hip patients. But the MVIC, or the maximal voluntary isometric contraction on this, is quite low, and there are better options. And the thought is that while you're doing these in sideline, the psoas tends to slide across the postoperative anterior acetabular rim, and it can be quite irritable for some of these patients. Again, I'm sure many have gotten away with it, and most patients don't notice anything, but there are better exercises to get glute med strengthened. So here, this is a study out of the International Journal of Sports PT. I know the text is a little hard to read, so I'll draw some arrows here, but you have 3 different studies here that are showing the MVIC of the clamshell. And you can compare and contrast this to something like basically standing hip abduction at the ankle, or like we call it like a monster walk with your legs straight, has a very high MVIC. And then side bridges with hip abduction with the surgical side down also has a very high MVIC. So a good study to reference if you're trying to be as purposeful as you can with your therapeutic exercise programming. So we keep talking about basic hip flexor loading. So this is, again, there's a million ways to do this. This is kind of the progression that I'll do. I'll treat it like any other tendinopathy. You're first going to start with submaximal hip isometrics. You can have the patient do this in supine, applying their own pressure, to the distal femur. You can also have them do this in a chair under a desk. Honestly, you probably want to have a more supportive chair than this, but appreciate I'm leaning back so we're not closing that hip flexion angle, which might be irritable for a post-operative hip. And all I'm doing is pulling up submaximally into the table there with my hip flexors. Okay, next is the active assisted range of motion heel slide. You can, depending on how irritable the hip is, you can tell the patient do 50-50 hands and hip flexor. You can have them work concentrically and let them go eccentrically. This is a personal favorite for actually introducing like pure active range of motion. They can lean on a countertop at home, take their shoe off, and do this on the kitchen tile floor. And then after that is just your generic toe taps, using a dowel for balance if needed. Just coming up and then back down. Okay. If anyone's interested, this is a decent screenshot of all the things we've just talked about, but just kind of highlights the recommendations that we've talked about up to this point. So before you pass out of this phase, the first phase, anywhere between 0 to 4 or 0 to 6 weeks, you want to ask yourself again, do we have a quiet hip? that is ready to tolerate and accept more load as we get further through the rehab journey. That's very important. If you have a reactive hip, you may want to stay in this phase, maybe another week or two, and ask yourself if any of the exercises you're giving are irritable, and just take a step back and make sure you're checking all your boxes. Okay. So now we're between 6 and 12 weeks out. Still, we want to protect the joint. But now we're focusing more on restoring full range of motion, which we should have by 12 weeks. If you don't have it by 12 weeks, I can promise you the hip arthroscopist that you're working with is going to start to remind you. And you're going to want to beginning to transition your rehab focus from muscle activation to more strength type programming. It's important to note that you're going to want to build an endurance base prior to pushing deep into advanced strength exercises. We're going to continue to intentionally and progressively load the hip flexors. And then we're basically preparing the patient for the next milestone, which is running, which typically happens around 12 weeks, plus or minus a week or two. I put in here in a lot of protocols, you'll see hip manual mobilizations. Those can probably be introduced in this phase if warranted, but we're going to talk about those deeper here in a little bit. And again, just to reiterate, at this point, again, range of motion is the responsibility of the patient. If they have an area that they're falling behind on, we will work with that each session to make sure that comes along. But for the most part, I want the patient to be doing those exercises that we talked about sending them home with earlier. Okay, again, million right answers here, but these are just some examples. Anywhere between 6 and 10 weeks, I'm starting to introduce squats, leg presses, and lunges that probably go to 45 degrees. Between 10 to 12 weeks, I'm starting to feel a little bit safer about the tolerance of the hip to go down to 90. Have I worked outside of these before and introduced the 90-degree squats at 9 weeks? I sure have. It's just dependent on where the patient is and just being appropriate and thoughtful when you start to introduce them to this. So the hip arthroscopist I was telling you about before, Dr. Mathers out of Duke, he would always tell his patients about the 6-week blues. So I stole it and I want to talk about it because I think it's a great term. The 6-week blues often happen. The patient has weeks 0 to 6 to basically keep the hip pretty quiet. A physical therapist that may not be as experienced with hips may not stress the hip enough to give it some adaptations to load and some tolerance to load. So they get off their crutches and they go from nothing to everything really, really quick. They'll have a day or two of a honeymoon phase where like, I feel great. And then their hip gets really flared up. It's very common. You could call this the 4-week 6 blues or the 6-week blues. Whenever they get off their crutches, it's just something to be aware of. So on the slide here, sharp increases in weight bearing, loading, and general lack of awareness by the clinician who's rehabbing them. Again, establishing a quiet hip during weeks 0 to 6 doesn't mean it's not exposed to load. Rather, it infers you're trying to help the hip become more tolerant of load. And again, we talked about how a hip flexor tendinopathy is analogous with a patellar tendinopathy in ACL rehab. So here's some different exercise ideas between week 6 to 10. Again, these are just some ones that I use. This is a 45-degree box squat. I'm in a staggered stance here, so my left leg would be my post-operative hip. It's going to bias it a little bit more. And you can easily load this. This is going to be a quad dominant exercise that isn't too much stress on a post-op hip. Okay, here you can do wall ball squats. This is more of a hip dominant exercise, only going down to 45 degrees here. TheraBand to kind of cue a little bit of isometric hip abduction. Okay, you can do either a regular or staggered stance again. If you're kind of in these phases where the hip is still a little bit reactive, but you want to strengthen it, you can add a Tabata timer to this. And this is actually harder than you think it would be. But in the orange there, you can see I'm just doing kind of reps over and over. When it hits 0, it's going to turn green, and you're going to perform an isometric hold. And as I was practicing this presentation yesterday, I realized I made the rest time really long. So hold on 1 sec while that goes down. And then when it hits 0, you get 5 seconds to rest in between. And that can be a pretty decent burner for these patients. I like to do, in terms of deep hip rotator strengthening, prone hip IR and ER. Here, this is coupled with BFR. This is killer. This is very challenging for these patients, but is a good position for a hip that may still be a little reactive after surgery. And then finally, you can do double leg or single leg bridges, a good cue to be more hip specific or glute focused, as you can pull the toes up in a dorsiflexion to feel more of a burn there. And then from there, you can work on single leg bridges as well. And this is coupled with BFR and You can't see Kelsey's distress as she has her mask on, but these are, man, these are hard. Okay, from here, some single leg hip specific balancing. You could do single leg balancing on an RX pad through your foot. This is just a fun way to isolate the hip and work on a little bit of proprioception. I would introduce this carefully. This can be a lot of load for a hip, so make sure it's just at an appropriate point in your rehab. And then some different monster walk variations. Us PTs love our monster walks. So that's, you can do above the ankles. You can increase the lever arm down to the ankles. And then finally, we talked about one of the highest MBIC exercises is just long lever arm, straight legs, straight leg monster walk variation. Okay, then back to, we progressed out of our basic hip flexor exercises, and now we're doing advanced hip flexor loading. So here are some different recommendations or things that I like to do. So here you have a supine TheraBand hip flexion, TheraBand around the dorsum of each foot. Just practicing marching up to 90 degrees there. Okay. Next, you can add a little bit of gravity to it, and you can do this leaning out against the wall. This is also a little bit more, specific for running type form, if your patients are itching to get back to jogging or running again. Okay, and then finally, some weighted hip flexion. You can put your foot through the hole of a kettlebell handle. You can perform these isotonically. You can pull the leg up and perform it eccentrically, and use a dowel there for balance as you'd like. But that tends to be a really, really hard one for these folks. Okay, so let's talk a bit about mobilizations. So for those in the room that don't know what a mobilization is, it's basically manual therapy of when a physical therapist or a chiropractor or an athletic trainer will basically mobilize the capsule in an effort to improve range of motion. These are often included within post-operative protocols, but with surprisingly little detail. Doing these pretty early post-operatively may not always be the best idea after a capsulotomy. And in the past, we've attributed range of motion improvements from these due to the mechanical principles of ligamentous deformation. But this has largely been left behind, and we know now that these probably work in different mechanisms that are outside some of these mechanical principles. There's a really fun study from 2008 from some biomedical engineers that is far above my pay grade. But basically, they created three-dimensional mathematical models for exploring the relationship of fascial deformation with the manual therapy of clinicians. And basically what they found is extremely large forces were required to create even 1% shear or 1% compression in thick tissues like the fascia lata or the plantar fascia. And basically in the conclusion, they say manual therapy releases may be more applicable to tissues such as the superficial nasal fascia. And a lot of our athletes request soft tissue, but I don't think I've heard that one yet in clinic, soft tissue for the nose. But if we're having that much trouble on tissues like the fascia lata or the plantar fascia, how much do you think we need to apply through the capsule of the hip, some of the thickest ligaments in the body? To drive that home more, there was a study in 2011 that basically found manual therapists were able to exert between 3 and 14 kilograms of force on a posterior shoulder capsule. And, they basically found that a shoulder capsule can withstand forces up to, 683 kilograms per centimeter squared. So we're not even beginning to touch the limits of what would actually cause true stretch in these capsules. Okay. Again, like we just mentioned, more modern manual therapy research supports that there are some neurophysiological mechanisms at play. And regardless of the mechanism, these do work. They can help a cranky hip calm down, and you can get some transient improvements in range of motion. It's just the narrative that we tell patients is what scares me the most. So for those who have not seen hip mobilizations, I thought I'd put a couple videos in here. A very common one is basically long axis hip distraction using the mobilization belt just around my hands here. Basically, I do not have to work hard for these, so I love this mobilization, but you basically just lean back and get a little bit of distraction at the hip joint. And for a lot of folks that come in and feel like their hip joint is compressed or they have an irritable hip, these can be quite helpful. Okay, this is a lateral hip mobilization. So basically the mobilization belt is around my bottom there. Put a towel on the inside of the thigh for a little bit of discomfort. And then basically all I have to do is lean back to get some nice distraction there at the hip as well. Of the two, long axis hip distraction is usually more tolerated easily than that one. This is good for your folks with FAI that you're trying to manage conservatively. You can imagine you're distracting the joint and giving it a little bit of more space to go up into hip flexion with. This is kind of a money mobilization here. And then finally, this one I would be especially careful with the post-operative hip patient. This is a PA mobilization. This gives a really good stretch or stretch-like sensation to the anterior capsule of the hip. But again, choose that wisely if working with the post-operative hip. So between weeks 10 and 12, if your range of motion isn't full by now, you can start to get pretty aggressive with your terminal stretches. Moderate pain is now acceptable because we're starting to get to a phase where we have to go. Certainly, you don't want to make the hip reactive. When you have a reactive hip, you can often go backwards in your range of motion, but just know if you're at the 10-week mark and you're starting to, if you're not where you need to be range of motion wise, you have to start getting after it a bit more. This is a time where aggressive mobilizations may be warranted. Aggressive, I use that term lightly, but mobilizations with intention. Basically, your local tissue capacity at the hip should be developed enough to now tolerate strength training. So again, strength is kind of an ambiguous word. If we just review the parameters of what strength training is. So for true strength gains, it's said between 1 to 5 repetitions per set with 80 to 100% of a 1 RM. And that sounds really scary within the post-operative crowd. So sometimes what's better to kind of work towards is 8 to 12 repetitions per set between 60 to 80% of a 1 RM. And that optimizes hypertrophic gains. This is kind of a famous illustration that works its way around the strength conditioning world and the rehabilitative world. And you can see on the y-axis, you have your training goal, and the x-axis, you have your basically the amount of repetitions you can do. And we want to be living here with these patients. So appreciating that if you've done all the right things in the first 10 weeks of your rehab, they're going to be able to tolerate strength training. If they're not, again, you need to take a few steps back and see what you missed, because you certainly should be doing heavier loads now. Again, while recognizing you probably don't want to push aggressively deep into flexion or aggressively deep into any exercises that predispose the hip towards flexion and internal rotation. So just something to keep in mind. Physical therapists are stereotyped by not being hard enough on our post-operative patients, which is where our strength conditioning partners really shine. But we can share this too, and we should definitely own this between weeks 10 and 12. So by this time, you should be doing your compound lifts, deadlifts, squats, hex bar deadlifts, step ups, and you're going to basically progress your exercises based on the hip's tolerance. Back in 2003 by Fry et al., this is kind of a famous study that looked at the old recommendation of like never let your knees pass your toes. So it's kind of interesting. So on the left-hand side here, you have someone doing an unrestricted squat. If you look at the hip torque, it's fairly low in comparison to the knee torque. But if you block the knees from passing the toes, look how much higher the hip torque goes in this. So keeping this in mind, you want to be really cognizant of your quad. So your quad dominant exercises would be picture A here, and your hip dominant exercises are going to be picture B here. Both you can use strategically. Do you have an irritable hip? Do you have a tolerant hip? Do you still want to strengthen, but you don't want to load the hip as much and you want to load the knee more? These are principles that are really important in the post-operative hip world. Okay, Mason, no better person to help show some strength exercises than strength coach Mason next door. So here on the left-hand side, we have an elevated hex bar deadlift. And we basically have his feet up on risers. That's going to make his knees translate forward a little bit more. I like the hex bar deadlift. It's very easy to coach. Patients generally feel very safe in it. They can hold good form because basically the way the bar is shaped, it's going to force you to lift it in the trajectory that we want. And then you can raise that up higher again, so your patient doesn't have to work too deep into hip flexion. And on the right-hand side, we just have the hex bar lift from the ground. Okay, next we can move to a front squat, different variations of how you can hold the bar if your patient doesn't have the flexibility to get their elbows up in this position, but this is certainly a quad dominant exercise. And then finally, you can transition to the back squat. You can, again, appreciate that more weight is going to be back through the hip as the bar goes from the front of the body to the back. And then to polish this up even more, you have a high bar back squat and a low bar back squat. A low bar back squat being probably the most challenging for the hip. Okay, between weeks 12 and 6, you should be in a heavy block of strength training. This should feel less like rehabilitation and more like they're in a gym training to get strong. At this phase, you likely want to get a baseline isokinetic strength test on an isokinetic dynamometer or a biodex. And then you're thinking in this phase of initiating a jogging program if someone's ready for it. So here's Nat, and I think Nat's on the call, so I know she's going to love this photo. This is her doing a isokinetic dynamometry test. This machine is called a biodex. It's basically, for those of you who haven't seen it, $50,000 machine. It's kind of the gold standard of strength measurement in the rehab world. It gives you a ton of different metrics. Here we're testing her quad and her hamstring strength. And then it gives you deficits from side to side. And PTs get real excited about this stuff. It's some really fun information to look at, and objectifies strength. A lot of times patients and athletes will say, I feel like this, I feel off, I feel good. But it's much easier to hang your hat on something objective, like a biodex report, to say, hey, you're feeling that way because of this. So very, very important. And it's an awesome privilege to have one in our clinic because they're not cheap. And this is what that will look like. So this is at 60 degrees per second. And regardless of how hard Nat is pushing, that machine won't go faster than 60 degrees, which is what makes it an isokinetic contraction. So many different criteria for jogging. This is the one that I use. You can see there's some different metrics that I'll look at in terms of pain, strength, time out from surgery, range motion, endurance. There's probably no right answer for this other than you should be objective, and it should have a component of the hip feet being quiet, strength being high enough. So here we have 80% quad limb symmetry index from side to side. So is the post-operative quad on the post-operative hip 80% of its uninvolved counterpart? And then are they out 12 weeks from surgery? Okay, I will often use something called the Ultra-G treadmill. The Ultra-G treadmill was kind of born from some technology out of NASA. It can get down to 20% of your regular body weight, and their kind of claim is the moon is 18% of your body weight. So I will usually introduce running on the Ultra-G. This is kind of an example of how I'll do it. I'll start at 80% body weight, have them walk for a little bit, then go back down, then go back up, and then go back down. And if they're able to tolerate full body weight in there carefully, they're good to go for jogging by my standards. If you haven't seen one, this is what an Ultra-G looks like. And I apologize, I just saw my time. I'm at 1:55 here. Okay, and here's basically, this is a good walk jog programming that I've used for the 7 years of my career. This is produced out of Ohio State, and you can just see that it's progressive in nature. Starts with 4 minutes walk, 1 minute run, and then slowly the ratio flips to the point that you're running exclusively. From weeks 16 to 24 weeks, focusing on plyometrics, agility training, sports-specific movements. I mean, we could talk about this for a 2-hour-long lecture. There are so many things you can do here, but just know you don't have to get too flashy with your therapeutic exercise training. You can certainly expose the athletes to loads and scenarios that they might see in sport, but I'm kind of a simple as better guy. I just don't think you have to get too flashy. And then finally, you want to be looking at your objective return to play testing. So I'll kind of bounce through this quick just for the sake of time. Here are some different objective tests that are around in the sports physical therapy world. Okay, we talked about the Biodex isokinetic dynamometry. You want these patients to have 90% of the strength in their operative side that they have in their uninvolved side, and this machine will help you test that. Many metrics, including peak torque, total work, rate of force development, and coefficient of variation that we could have a lecture for in itself. There is something called hop testing. This is big in the ACL return to play world. Again, you're looking for a score of 90% or higher from the surgical limb compared to the uninvolved side. It's important to note when you use this in isolation, it can sometimes overestimate the injured limb's function. So you want to make sure you pair this with some of the other things we're talking about. Y balance test, you're basically in single leg stance, pushing out in the 3 directions. Again, your cutoff is basically 90% or higher in terms of limb symmetry. And they found through research that if there's a 4 centimeter difference from side to side anteriorly, that it places you at increased risk of injury. Okay, this is called the landing error scoring system. Again, this is used more in the ACL world, but you better believe that it will still be pertinent and helpful for your post-operative hip patients. It just objectifies how we can look at landing mechanics and if they're clean or abnormal. Obviously, things on here like knee valgus, initial foot contact, do they land with one foot prior to the other? Do they lean one way or the other in terms of trunk side flexion? And anything higher than 5, the makers of the test basically say you need to be targeted for additional like therapeutic exercise programming or corrective exercise programming. This is called the tuck jump assessment. This is really hard. This guy is a professional soccer player, and he's probably the best one I've ever taken a video of. But here you have some different objective criteria to kind of grade this jump. You want it to be like golf. You want to get closer to 0 for a better score. Anything higher than 6, and you're thought to be at increased injury risk. In terms of return to play rate, a recent 2022 systematic review included 130 studies with 14,000 patients, and they found that basically there's a return to play rate of about 85% over a mean of about 6 months, which I think sounds about right. Interestingly, and this is what we always talk about in the rehab world, sports medicine world, sure, it's a return to play, but is it a return to play at the level they were previously competing at? And we found that this study found that generally 72% of these folks get back to their pre-injury level. And that's not good enough. That needs to be higher. In terms of objective criteria to release back to sport, time was the most common thing out from surgery. So using your return to play tests are important. And most studies recommend a return to play anywhere between 3 to 6 months. Okay, another systematic review. This was done entirely on elite athletes, which is good for the population we see here at the training center. And they found that 94% of these patients demonstrated return to play anywhere between 7 plus or minus 2 months. And then 10% of these patients required further intervention. Okay, we're almost done here. I know we're short on time, but anything left that needs to be addressed between weeks 24 to 1 year, I just consider polishing up. These folks are probably likely transition back to the strength and conditioning team now. I continue to recommend serial testing on the Biodex. And subjectively, like most patients won't feel completely normal again until 1 year post-op. And it's important to reassure them of that, even if they go back to return to play 6, 7, 8 months out from surgery. So in summary, bringing it all home, many unique surgical considerations that influence the first several weeks of post-operative rehab. There are many right answers and few wrong, but remember some of the niche areas or pearls related to the arthroscopic hip, neuropraxias, capsulotomies, hip flexor load capacities. You want to respect the anatomy involved in arthroscopic surgery. The big one is you don't have to aggressively squat past 90 degrees. And you definitely want to honor that because your hip arthroscopist is going to ask to limit that. Again, appreciating the interacetabular rim and the freshly repaired labrum. But once it's appropriate, remember to load heavy and often. Isokinetic dynamometry and return to play testing are going to decide your decision making. And then athletes post hip arthroscopy have decent return to play rates, but reaching pre-injury levels of competition is lower than we'd like it to be. These are my references. Oh gosh, I thought they all came up at once, but here they are one at a time. And here is my email. If you'd like the presentation, have any follow-up questions, or just want to talk shop on anything, you are welcome to reach out at any time. So I know that is up to the 2 p.m. hour, and I know I personally have a patient right now. If there are any follow-up questions, please feel free to screenshot this and hit me up, and I'd love to talk a little bit more. But thanks all for being here, and have a good rest of your day. Jenna, anything else you need from your end?
Nope, that's wonderful. And thank you so much for your time today, Chris. We are right up to that 2 o'clock mark. So if there are any questions, I'll encourage our attendees to drop Chris an email, or feel free to email me as well. I'll be happy to share a question with Chris, and we can guarantee he will get back to you with an answer. But other than that, please keep an eye open for the post-event survey to come out by the end of day tomorrow for you. And if you want to get continuing education unit credits for this lecture, and that survey must be completed within the next 2 weeks. And remember to save your certificate at the end of that survey, because we will not be sending out individual certificates. Other than that, thank you for attending, everyone, and we look forward to seeing you for our next presentation. Have a great day.
See you guys. Thanks again.